Okay, good afternoon, everybody. Hope this PowerPoint finds y'all doing well. This goes right along with the pharmacology PowerPoint that we have posted in the course, so you can follow along with that. I don't believe there have been any changes from that to this. So, so we're just going to follow in the steps taken last go round on Tuesday. And when we're talking about pharmacokinetics and medication prescribing principles that you really want to attend to with a specialty population, with folks in the geriatric population, I guess a lot of places will define that as 65 and up, so we'll go with that. And just kind of remember back from patho and that first year pharmacology course, talking about how prescribing is different and why it's different in the population of adults over 65. People who may have reduced renal clearance, reduced hepatic perfusion, and therefore reduced hepatic efficiency, the changes to albumin, to the proteins in the blood, and how that affects availability and activity of medications, those kinds of things, those physiology differences, how labs might be different. Working at the VA, you'll pull up a patient's med record and it'll send you a message before you write a new medicine that says this patient's on 21 medications, polypharmacy. And that adverse effect profile may be different in an older adult population too. Specifically, we're going to talk about the drugs, really the ones that you're more likely to be prescribing for an older population from a psychiatric mental health standpoint. Problems with memory, so those major neurocognitive disorders or dementia, and then the most common mood disorder and generalized anxiety. You remember, I'm sure, from last go-round, absorption, distribution, metabolism, excretion, the pharmacokinetics, how drugs move around the body, and things that might influence when you look at the normal curve of our lives, you have most of your life, you have pretty average, middle of the road, appropriate process of absorption or process of metabolism. But then as you age and the bell curve flattens out, there's going to be some differences. And consider, think back to why, in particular with the older adult population, why metabolism and excretion may be different. In particular, absorption should be roughly the same. Maybe there's reduced perfusion to the gut. Maybe the gut and the small intestine is a little less efficient at absorbing things, so maybe less drug really gets through. Maybe, sure. But the main prescribing concepts you're keeping in mind is that the drug's going to be probably at a higher dose than I predict, and it's probably going to stick around longer than a 30-year-old patient with no other kind of health conditions. From a distribution standpoint, that's a little different, because as the human body ages, you have a relative decrease in lean muscle mass, and you have therefore a relative increase in fat. You have a relative decrease in just water, total body water. You have a relative decrease in the amount of available proteins floating around in the bloodstream. So that means there's going to be more active drug, relative, okay? Because it may be a higher concentration of the drug in the circulation. And the drug that's there isn't going to be able to bind as much to the things it likes to bind to the proteins. So you'll have more active drug. And if 50 milligrams of Zoloft that may translate to more like 75 to 100 milligrams of Zoloft in someone who's 72, then that means I'm not going to go as high, and I certainly won't increase as quickly. Reduced perfusion to the kidneys and to the liver for a variety of reasons. As we age, we just get less efficient from a cardiac standpoint. The arteries going to these organs are starting to sclerose and shrink, and they don't have as much of a pulse as they previously did. So less blood getting to your kidneys means less filtering out, less blood going to the liver means less nutrients to the liver, so it's going to shrink. It's not going to be as efficient. You'll have just more active drug kind of all the time. And reduced GI motility. Just think that another consideration is as you're prescribing drugs that may also have a sort of anticholinergic side effect to them, which we want to be careful in older adults anyway, is you already have a reduced GI motility or an increased transit time. You don't want to make that even more significant. So just things to consider. Long story short, there's a chance that their drug level is higher and drugs will last longer, so an extended release medication will be really, really, really extended. So you won't necessarily want to go straight to the extended release Effexor or some drug that maybe has an extended release core that's going to send you a second pulse in however long down the road. Drugs will stay in the system longer. They'll be active longer. In particular, if you're prescribing a drug like lithium, for example, that is entirely dependent on renal clearance to get out of there, you want to be very vigilant for electrolyte levels. Getting a CMP, I mean, potentially you could justify doing that every 6 months or with any changes as well. This is for somebody just on any sort of medication, not necessarily lithium. Probably if I had somebody who was in their 70s and on lithium, I could justify doing a lithium every 3 months. They're on so many different medications. Oh my goodness. It's the only way to know for sure. You would do every 6 months anyway, but you could justify doing it a little more often. And electrolyte imbalances, sodium gets too low, potassium gets too high, you'd be concerned about calcium, concerned about magnesium. Any of those things can cause confusion, can cause dizziness, can cause weakness. And again, the protein binding issue because there's just more drug available. It takes longer to get out of there. The half-life's going to be longer. A washout will take longer as well. So none of this is really earth-shattering. You monitor metabolic activity of all your patients. Hopefully they're getting lab work done every year. Now, as folks age, you would want to get that potentially more frequently. Buspar is another medicine that you would want to keep an eye out for relative to renal clearance because Buspar is very dependent upon renal excretion to get out of there. These are the lab values that you would always just want to know what a normal is. A creatinine around 1, BUN 10, teens, GFR over 60 and over 90 because it's really wanted over 90, but then it's okay if it's 50 or 60. No one's going to get upset if it's over 60 and even somewhere in the 50s. Not a huge concern. And then, you base it. You want to know your crit and hemoglobin ranges for men and women, a normal platelet, especially if you're writing a drug that might affect clotting times, which Zoloft can. Zoloft can certainly do that. Mirtazapine can, in very rare cases, can cause a drop in your white count. So you just want to know, always want to know what these are and check them out when you get labs, hopefully every year. Elderly population is probably taking a statin and a couple of blood pressure medicines and a PPI and something for arthritis and maybe something for The gentleman will be taking something for prostate. So it could be tons and tons and tons of things that can affect renal clearance, probably more than anything, all of those, the blood pressure medicines. They'll be on Mobic, they might be on Neurontin. I mean, you've seen these. There's lots and lots of medications often. So how do you deal with that? How do you deal with the polypharmacy? How do you deal with the physiological changes that happen with aging? Well, then take a conservative approach and start low and increase slowly. But monitor for treatment effect and keep in your mind when you should start seeing an effect, and know, okay, if it's been 2 months at this dose of Lexapro and the patient's score on the geriatric depression scale hasn't changed at all. 2 months is too long to not notice a change. But if it's 2 weeks, then, and they're tolerating the side effects, then you may want to go ahead and increase it if you're at a really low dose. But again, there's a lot of competition for those protein binding sites. There's a lot of competition with those CYP enzymes to break these medicines down. And there's a lot of competition to get things out through the renal filtration system. So starting low, you may get more bang for your buck because of all those issues. Short half-life is good. Ativan versus Valium or Klonopin, these longer half-life medications. Can you pick something that's less anticholinergic? Risperdal is going to be less anticholinergic than maybe Seroquel or Zyprexa is going to be. Can you make those choices? Start with those options if you have them. And be sure to educate your patients on what antihistaminic side effects are going to look like and what antiadrenergic side effects are going to look like. The importance of hydration for various reasons. You want to be sure you're going to support renal perfusion as best you can, assuming, of course, the patient doesn't have some kind of fluid restriction for a comorbid medical condition. So we introduced this on Tuesday, kind of a revisiting of the current, it's a couple different parallel theories on what causes Alzheimer's disease, and kind of the one that's had the most footing for the longest time is an acetylcholine insufficiency deficit that is contributing to the cognitive impairment, the memory and the executive function impairment. Part of what supports that theory is drugs that are strongly anticholinergic will give everybody a hard time in forming new memories, learning new information, and cognitive tasks. So that does support the idea that acetylcholine is it's important. It's pivotal for learning cognition. Synthesized in the basalis of Maynard and projects to some really important memory places, including frontal cortex, hippocampus, and amygdala, those structures involved in learning new things, deciding what's important, deciding what needs to be stored forever. And receptors for acetylcholine, there are two different families, I guess you'd say, muscarinic and nicotinic. And they're named that way because they find that the active chemical in one of those mushrooms, I don't think it's a magic mushroom per se, it's a chemical that has a high affinity for those particular receptors, muscarinic receptors. So when we talk about anticholinergic side effects like my vision's bad and I can't pee and my mouth is so dry, we're really referring to muscarinic blockade of when we say anticholinergic side effects, more specifically muscarinic. But the nicotinic receptors, when they are involved and activated, what you have is more a process of aiding memory. Of course, muscarinic receptors are involved in memory too, but nicotinic is, I guess, more specialized for memory and reward. These nicotinic receptors are more excitatory. When they have a little acetylcholine land on them, you tend to have activation. Further release of neurotransmitters is promoted into, you see the frontal cortex and things. So you might have further acetylcholine release, more norepinephrine release, more dopamine release, things that are pro-cognitive. Really good to have dopamine and norepinephrine released in your frontal cortex. It helps with attention and response control and selection and planning. So it's good when you have nicotine receptors occupied. And sometimes when they're occupied by nicotine, they can even cause the release of dopamine into the nucleus accumbens, the reward center. The suspicion is that that's what cigarettes act upon, is it cuts straight to the chase to the nucleus accumbens, and that's why people have such difficulty stopping. Almost sounds like it turns into a compulsive behavior, the difficulty that people have not engaging in smoking. So those are the two different families of acetylcholine receptors, real important in memory formation. From our standpoint, what we're more concerned about now, important for reward, seeking out behaviors. This is good, going to do that, let me do that. So not a surprise that as acetylcholine drops, you may, in this way, and those nicotinic receptors are not activated as much, how there may be a further reduction, real drastic reduction in activity in those ADLs. I mean, even the get up and go to go and do basic life stuff. You see that decline as well in these major neurocognitive disorders. So those muscarinic, we mentioned, those have a lot of activity with more basic physiological functions like your gut, GI, GU. So, and that will come into play when we talk about manipulating acetylcholine and some of the side effects. Cholinesterase inhibitors, anytime you see an ASC, that means it's an enzyme. So these are the inhibitors that, I'm sorry, not the inhibitors, these are the enzymes, cholinesterase enzymes. Their job is to break down acetylcholine into other little components. They exist in nerve terminals of neurons who are going to eventually release acetylcholine. So they break it down. Two kinds of enzymes, acetylcholinesterase and I say butyrylcholinesterase. Let me double check that that's not butyrylcholinesterase. So I'm going to triple check that. It's the only one that's a B that's relevant. So you have the A, acetylcholinesterase, and then the B, butyl. But again, I'm thinking that's butyrylcholinesterase. What's important about that is that it exists not in cortical neurons, but in support cells. In those glial cells, they kind of exist in surrounding all the other neurons, and they have activity as well. Some of them have activity in the inflammation process and trying to keep the riffraff out. So when we're talking about the main ones, really it's acetylcholinesterase it is the one primarily responsible for the breakdown of acetylcholine. This butyryl, and it is butyryl, so there should be an R and a Y in there. Butyrylcholinesterase doesn't do a whole lot in people, so a suspicion is that this used to be more important in our evolutionary history, but for whatever reason, as we've evolved, acetylcholine does the majority of the heavy lifting in the process of breaking down acetylcholine. They've done studies where they'll create mice who don't have any acetylcholinesterase at all, and then the mice, therefore, they have to rely on the butyrylcholinesterase to break down, and it kind of picks up the pace and does fine. So Even though it's not active, it will be relevant in just a moment when we talk about that. So cholinesterase. If it's trying to break down acetylcholine and you prevent its ability to break it down, then you end up with more acetylcholine available to do what it does, to land on these nicotinic and muscarinic receptors and support memory, support the release of other cognitive enhancing neurotransmitters. Great. The problem is that it seems to be only helpful in mild to moderate Alzheimer's disease. And we're going to talk specifically about Alzheimer's with these drugs because that's really what these are designed for, even though there are many different causes of dementia, for lack of a better word. These cholinesterase inhibitors really are targeting Alzheimer's in particular. But it's also, Alzheimer's is the most common cause of it, so that's appropriate. But you have donepezil, which is your Aricept. You have your rivastigmine, Exelon, and galantamine, the Razidine. So those are the three cholinesterase inhibitors. Aricept for mild to moderate. You see a lot of folks get started on this. A lot of randomized clinical trials show that it does separate from placebo in studies when they'll do mini mental status scores for folks. They'll start one group on Aricept and another group on a sugar pill, and they find a significant, not improvement, the decline is less. The folks who were on a cholinesterase inhibitor after a year will have the same or similar mini mental status score. The group who did not will have a mini mental that's maybe 2.5 points lower than where they started. So there's not an increase in mental status. There's a maintenance. That's what you see with these cholinesterase inhibitors. It doesn't reverse, it doesn't prevent, it doesn't improve. You maintain. So what seems to happen is whatever underlying mechanism that's causing the destruction of all of these acetylcholine releasing neurons, that process is ongoing unaffected. Just any acetylcholine neuron who's left is prompted to, you get all the bang for your buck because you're never breaking it down. You're keeping it all available. Not unlike how the Parkinson's medicines work. Doesn't necessarily cause an extra release of it. You just prevent the breakdown of what's available to be made. But again, for mild to moderate. If someone with a mini mental status score of 20, 22, that's more your mild, middle teens, somewhere in the teens for more moderate. These medicines would be okay. Exelon works a little differently. The only thing Aricept does is blocks acetylcholinesterase, but Exelon blocks that butyrylcholinesterase as well. So how might that be helpful in, moderate disease, not just the initial starting off disease, but maybe moderate disease, is as cortical neurons have been lost, along with them you lose the acetylcholinesterase enzymes. So why bother blocking an enzyme that's not even there to help maintain what acetylcholine is left? So that may be the benefit by this additional inhibition of the butyrylcholinesterase, is you still have the glial cells there with their enzyme. It blocks that too. So maybe that helps. Maybe that's why. They don't know for sure, but that's their suspicion. The problem with it is you have more GI side effects if taken orally, so that's why you see people with the Exelon patch. The transdermal patch, it skips that. We have a lot of parasympathetic innervation to your gut. That's a rest and digest activity. So if we're increasing the amount of acetylcholine hanging around, you're going to have the opposite of anticholinergic side effects. You'll have increased GI motility. So some of the main complaints with these medicines, you'll have diarrhea that may limit dose up titration. You may have nausea. If you remember when we talked about the antipsychotics and how they have those anticholinergic side effects. And we talked about how those muscarinic receptors are involved in feeling satiated. So if you block those muscarinic receptors, you end up feeling hungry all the time. Well, these drugs are doing the opposite. They're increasing acetylcholine transmission. So you have, with these drugs, very often just a reduction in appetite, and you can have significant weight loss, sufficient to discontinue therapy at times. So you may have weight loss, reduced feeding behavior. Folks will have, again, that diarrhea, GI disturbance. They'll complain of dizziness. Falls are not at all uncommon. But also, your vagus nerve, via cholinergic transmission, affects heart rate. So if you're upping acetylcholine, then you are increasing your body's ability to slow your heart rate at the AV node. So symptomatic bradycardia is possible with these drugs too. So you would always check heart rate and make sure the patient and family members around know to keep an eye on heart rate, to be very careful with the risk of orthostasis with that, especially if they're taking other blood pressure medicines. So things to consider: the stomach, heart rate, diet, eating, weight loss, all a big concern. And this last one, Razidine, galantamine, the other cholinesterase inhibitor. In addition to that, one thing that this drug does is it actually helps those nicotinic receptors we were just talking about. Where'd you go? Yeah, these nicotinic receptors, this one alpha 7 in particular. Galantamine has an additional function. It's not the word I was looking for, but it's close enough. It has an additional ability to make any acetylcholine landing on this receptor will have a greater effect than it would by itself. And that's what we call that positive allosteric modulation. It's what benzos do at GABA receptors. It just makes the neurotransmitter landing there does more than it would otherwise. So in the presence of that Razidine, acetylcholine landed on that receptor results in a more prominent effect. So that's a good thing. When those receptors can subsequently result in even more acetylcholine getting released, it could be good. Norepinephrine, dopamine getting released. Good stuff. But these are more for mild to moderate disease, because you still need functional acetylcholine releasing neurons for any of these medicines to do anything. Now, for more advanced disease, so this is for the brain of a person who has had significant loss of cortical neurons. On scan, the hippocampi will be significantly atrophied. So where that is, that's on your temporal lobe, kind of tucked under toward the middle of your brain. It's going to be significantly shrunken. So those cells, those neurons in that tissue, they're gone. They've been lost to that inflammatory process that we talked about last week. It relates to the amyloid proteins triggering inflammation and triggering tau and triggering more inflammation, so on, so on. Stahl calls it the amyloid cascade. So there's less tissue. The cortex is thinning. Those cells are dying, probably due to overactivity, excitotoxicity from that inflammatory process. They're getting pruned out because the cells are damaged. You have more empty space, so the ventricles are larger, the cortex is thinner, the hippocampus is smaller. So no wonder they have trouble making new memories. And really with Alzheimer's, that's one of the key things about it is rapid forgetting. You can say, remember house, ball, car, and they won't remember house, ball, car. You can tell them a story and they won't be able to recall details to it. It's a hippocampus problem, trouble with learning new things. With more advanced disease, when you don't get any benefit for people with moderate, severe, that end of the spectrum, so a mini mental status score in the single digits, in the low teens, Aricept won't do anything. There's just no more acetylcholinesterase for them to act upon. There's been such loss, you have to approach it from a different way, and that's what memantine, that's where it comes into play. The plaques triggering the cascade of inflammation, cell death from the tangles, those tau proteins that are misshapen and make the cells tangle up, and they die. So you just have essentially waste and toxins and trash, for lack of a better word, just floating around in your brain from all these cells that have fallen apart and died because they weren't shaped right anymore. That is, anyone who's ever, if you've ever worked with someone who had a bleed into their abdomen, they will talk about how unbelievably painful that is, because all of the ingredients to your blood, these proteins and electrolytes, are very, very irritating to anywhere it's not supposed to be. It doesn't hurt you in your arteries and veins, but it's very painful to other tissues that are not designed to be exposed to those ingredients. Same thing in your brain. It's very irritating. How do you slow that down? How can you reduce some of that excitotoxicity that's just keeping cells a little bit depolarized? It's just keeping cells on. Typically, we have our NMDA receptors. We talked about that back in the context of the schizophrenia chapter. But NMDA receptors, they take glutamate. When glutamate lands on them, it tends to turn the cell on and results in some kind of cellular function, some release down at the other end of that neuron. Stahl's page 535 is what this slide is referring to. And it gives you a picture, an example of a normal resting neuron state. But then he gives you a depiction of, with Alzheimer's, when there is this excitotoxicity in this inflammatory state, how essentially a little bit of glutamate is constantly being released. So there's a little bit of glutamate sort of always trying to trickle down, land on that receptor, and keep that next cell on and on and on and on. Normally, I did this myself, as I'm sure you can tell. Here is my version of Stahl's picture. Typically, you got a glutamate neuron. It would land on this receptor, but there's some magnesium there. So, okay, not a problem. For whatever reason, in Alzheimer's disease, there is excess glutamate released, sufficient to overpower that magnesium. And the magnesium normally is blocking the channel at that receptor. NMDA receptors, again, they're ion channels, so really their job is to stay closed, or when they're open, let some other cation through. Could be sodium, could be calcium. It's calcium in this case. But with Alzheimer's disease, with all the excitotoxicity, there's just too much glutamate being released. It essentially overwhelms that receptor. So calcium is constantly coming in, and calcium, with its positive charge, is going to cause this cell to become depolarized and fire. With Alzheimer's disease, this never stops. There's a constant flux of glutamate here onto this receptor. So there's a little bit of calcium is just stuck in the on position. And that's not good for any cell in your body to be constantly being stimulated. There needs to be rest, there needs to be recovery, there needs to be a return to full polarization so that it can depolarize. But with Alzheimer's disease, this doesn't happen. Calcium constantly leaks in. Enzymes in the cell are overactive. There's constant metabolic need, metabolic waste. Inflammation increases. The cells can't keep up. The cells die. They're cleared out. That's what happens. So in this way, when the disease process is that advanced, the treatment of choice for these folks is going to be trying to interrupt that constant excitotoxic state by, let's go back to the slide. What memantine is trying to do is essentially step in for the magnesium and try to block this channel a little more firmly so that it's not a constant flow and a constant turn on signal for that next cell. And it's interesting because Aricept, memantine doesn't have any kind of clinical benefit for people with real mild Alzheimer's, and Aricept doesn't have any clinical benefit for people with more advanced Alzheimer's disease. So for someone that you strongly suspect Alzheimer's, you could prescribe Aricept, sure. And later in the disease, a lot of times what will happen is they'll augment with this. They may not necessarily discontinue the Aricept, but you would need to augment with something that is indicated for more moderate severe, the more severe end of the disease with a much lower mental status score. The downside to all of those medicines, though, is there's a short time limit of how long they're going to be effective. You can get a year or so, and then you can expect a significant decline once it's kind of like the medicines lose effectiveness. So you don't expect it to be effective, sort of pausing that decline. You don't expect that to be an indefinite response. And with all of these drugs as well, it's a significant but not a gigantic change when studied. But, to prevent a 2 or 3 point decline in a mental status for a year, and then maybe prevent the decline even beyond that, maybe not that robustly, but prevent it beyond that, sure. Because if you're losing 2 or 3 points a year for 5 years, you've gone from a 22 to a 10 or below. And severe disease due to Alzheimer's, that's when folks can no longer initiate just the basic activities of daily living. So if you can postpone that, really what you're doing is extending some degree of independence for themselves. Because magnesium is relevant to the activity of memantine, it would be valuable to get a magnesium level in particular for those patients, because you are prescribing something that functions similarly to magnesium. So for neuromuscular reasons, you want to be sure that you know what the mag level is to start with. So for all of those, you're monitoring for the cholinesterase inhibitors, you're monitoring cardiac, you're monitoring GI, provide primary prevention education to caregivers about fall prevention, monitoring for weight loss and eating, diet, those kinds of things. And again, those medicines are indicated for dementia, major neurocognitive disorder due to Alzheimer's disease. Those drugs can be written for, let's call it vascular dementia, and you'll see those drugs written for that, but there's no FDA indication for vascular dementia. There's really no kind of treatment like this to prevent or slow or correct vascular dementia. That's a totally different etiology of that for that disorder. Now, Lewy body dementia, these drugs, the cholinesterase inhibitors, may be helpful for that disease process as well. But vascular dementia is just tough because there's not a medication to make a significant benefit for that. That's more lifestyle. If you want to try to prevent Alzheimer's disease, Stahl has on page 515 a list of behaviors to encourage patients to try to prevent the progression from mild cognitive impairment toward mild Alzheimer's disease. And some of these real bad risk factors for Alzheimer's, you have diabetes, vascular disease, strokes, because there's insulin actually has activity that is neuroprotective. That insulin itself can promote healthy, normal functioning of tubulin, that protein that makes the tracks that our brains, that our neurons kind of run along. And when tubulin is misshapen, that's when you have the tangled up neurons that die. Well, insulin helps that maintenance of that system. So when you've developed diabetes and insulin is now at a premium, they find that folks with Alzheimer's disease tend to have lower levels of insulin. All the more reason to protect against development of that particular disease. Switching over to depression, which we started that conversation last go round as far as recognition of it in the geriatric population. Depression is not a normal process of aging, so it should be screened for and it should be treated. The good news is that most of the SSRIs you can prescribe to folks into their late years without a whole lot of concern. Not significantly more side effects at higher doses. One exception to that is citalopram, that you wouldn't go over 40 for anybody, 40 milligrams on that, because of its role in sodium channels and cardiac repolarization. But the rule that you want to go by for folks over 65, 70, depending, I'm sure, on the rest of their health and their cardiac history, is that the recommendation is not to go over 20 milligrams for folks over 65. So keep that in mind. Switch them to Lexapro, switch them to something else. You could get an EKG, but you'd need to monitor real closely regardless. But you don't go over 20 for folks who are older, 65 and up. SSRIs are great. TCAs, the tricyclics like your amitriptyline, nortriptyline, you're concerned because they block acetylcholine receptors. They block muscarinic receptors. It's the opposite of what we're trying to do if you're promoting cognition. MAOIs, we don't even really talk about those because there are so many more agents that are much safer. With geriatric depression, ECT, electroconvulsive therapy, is a really good option, even though you don't see it. You certainly don't see it advertised, probably because nobody's making money on it anymore. But an interesting study in the VA 5 or 6 years ago, they took the number of patients who saw mental health services and then took a percentage of how many received ECT. And of the thousands and thousands and thousands and thousands of people who saw mental health specifically for a depressive diagnosis, I should say, less than 0.5% received ECT as part of therapy. So you have that many folks being treated for depression and such a tiny percentage being treated with ECT. Now, ECT is highly effective. You can get a response rate from this treatment in 75% or more. Sometimes when you see these studies, it's 90% have remission for depressive symptoms. It's amazing. We just don't ever think to use it. And I don't know why, and I don't think anybody knows why. But the indications for ECT: severe depression, suicidality, a lot of psychomotor retardation, so folks who are just moving slow. I mean, really from an organism basic physiologic level, they are slowed. They may even be catatonic, not moving, not drinking, not eating. So for a patient with a severe depression with psychosis, depression with lots of suicidal ideation, suicidal behavior, there's an urgency there, ECT would be great. It's probably actually the ideal treatment. So I don't have a good reason as to why it's not done, except maybe you have to find a place that does it, and anesthesia and all that. And a lot of folks are very anxious about doing it. Main side effects: headaches, nausea, which tends to be treated before the procedure, and some hemodynamic instability. It is inducing a seizure. So with that, there's the potential for blood pressure to be varied, for it to vary widely. So you would be certainly cautious in patients who already have hemodynamic instability. But there are no absolute contraindications to ECT. If the person is severely psychiatrically ill, suicidal, or they're going to die if their depression, in other cases, this is also effective with schizophrenia, this is effective with bipolar disorder, not just with depression. But if the psychiatric picture warrants, there are no contraindications to it. You can read articles about people who've had heart transplants who do this, who need to do ECT. Main side effects is for a couple of months, maybe 1-2 months after the procedure, they will have difficulty remembering things, like learning new things. In other cases, folks may have trouble remembering a couple of months prior to the procedure. So you have anterograde and retrograde amnesia. The anterograde being trouble making new memories, event forward, or retrograde amnesia, event backwards. You have trouble remembering either way, but this also tends to resolve in all cases. So this is an option, especially if you have somebody who's on so many medications that they can't tolerate an antidepressant. There's some sensitivity to it. There's some contraindication to medication. That ECT often is the last resort, even though there are some cases, certain depressive presentations, that it would be the best thing to do first. But for patients with a comorbid personality disorder, they find that ECT is not at all effective. And studies say you don't need to discontinue medicines or change medicines before you do ECT, even if the person's on maybe an anti-epileptic, maybe the person's on a benzodiazepine, or the person's on a mood stabilizer. That ECT still tends to be as effective even with patients on those medicines, so you don't have to discontinue. For anxiety, which also may be a common presentation in the older adult, we talked about the benefit of short-acting medications, especially if you're talking about a benzo, which has the potential to slow cognitive functioning, impair steadiness of gait. Just be, that wouldn't be your first choice for anxiety treatment anyway, especially if it's GAD. then an SSRI would be the better choice. Anyway, Buspar is an option, but again, watch for renal clearance. Is there an issue with needing to reduce stimulation in the environment? This is almost referring more to people who may have a major neurocognitive disorder, that they get real overwhelmed and they need to be just verbally redirected. But even for an older adult, doesn't meet criteria for a neurocognitive disorder. Routine is good. Not being overly stimulated, but some sort of regular interaction with other people. Some kind of stimulation is necessary. Predictability is always good. And make sure substance isn't involved. I think that might be the last thing. Let me just make sure. That is it. So, having covered, go back to that slide. So we kind of covered Alzheimer's treatments for mild versus more severe illness, the different mechanisms of action, the side effects that you would look for, other indications for those medicines like Lewy body dementia, modest improvement for a short period of time, but not prevention, not indefinite improvement or maintenance, I should say. Medication treatments for depression, ECT. And the main thing is just keeping in mind other medications the person's on, education about side effects, and kind of the polypharmacy, pharmacokinetic concerns. So we're going to pause it here and upload that. And do not hesitate to send us any kind of questions you might have, okay? And look forward to hearing from y'all.